All right, so when we're looking at the patient, the OB patient, there are some big changes that kind of come into play here, as we've already talked about, and some that we'll continue to talk about. In musculoskeletal changes that occur within the patient, one of the things that we see, obviously, is that the center of gravity now begins to change for mom as the pregnancy progresses. The other thing that happens, and this is kind of a positive as well as a negative in regards to the delivery process to get mom ready for the actual delivery of the baby, is that certain hormones are secreted so that the joints now literally become more loose, more flexible to, in particular within the pelvis area, to allow the passage of the baby down into the birth canal. But now, here's the thing that I want to ask you as far as this goes. When you're looking at these changes that are happening, again, from a musculoskeletal perspective, what are some things that you need to be thinking about as far as your assessment and plan of care for mom, primarily from a musculoskeletal perspective? Very good. So, moms, especially late term, are always complaining of back pain because, again, keep in mind, and this will be important as we move into the next slide in just a little bit, between the amniotic fluid, the additional blood in the uterus, and the weight of the fetus itself, particularly at the very end of the pregnancy, that in and of itself may weigh anywhere from 25 to 30 pounds. And so it's out in the front of mom, and so it definitely is going to put some strain on the back. So that's one of the things to kind of keep in mind. What do you need to be concerned about as far as like her center of gravity? And specifically, how do pregnant females have a tendency to fall? How do they impact the ground? Yeah, very much so. Because remember, the baby is up high to begin with, and then now it begins to drop down towards the end of the gestation period. Again, the center of gravity moves back from here for those of us that are not pregnant, and it actually moves out here towards the front. So again, when you're assessing your patient, make sure that you're looking at the palms, assessing the joints of the arms and the shoulders, and in particular, looking and assessing for any potential trauma, abrasions, bruising on the mom's belly as far as that goes. Because again, just like you said, Bella, that's typically going to be how that patient is going to land. Now, this is a critically important concept as far as the care of your pregnant patient. In the last trimester of the pregnancy, there's a condition known as supine hypotensive syndrome. And what happens here is, remember, I said that all of the material, the fetus, the amniotic fluid, and the blood in the uterus can weigh as much as 30 or 25 to 30 pounds. And in doing so, when mom lays flat, what happens is it's going to compress the inferior vena cava. Now, remember, the aorta is an artery, John. It's fibrous, it's tough, it's muscular, okay, like all of our arteries are. So it does not compress the aorta, but what it does do is it compresses the inferior vena cava. Veins, very floppy. The inferior vena cava is probably about the size of your little finger in the adult. Now, when it depresses the inferior vena cava, what happens in this situation? What impact does it have on your mom? Tom, decreased preload. And what all does that mean, Tom, as far as decreased preload?
Well, since the vena cava is bringing blood back up to the heart, it's gonna like not be able to do that as effectively. So the heart's not gonna be able to fill and contract attract so much blood, it's going to lower the blood pressure.
Perfect. I could not have said it better myself. Yeah, you're exactly right. The illustration, I may have used it in here because I'm old and forgetful, but unlike the American Congress, they can spend the money it doesn't have. The human heart cannot pump out blood it doesn't have. So as mom is lying flat, all that weight compresses the inferior vena cava, reducing the preload down to just about nothing. And as a result, John, what do you think mom's signs and symptoms would be in this situation? How would she look?
Maybe pale. If the vena cava was getting compressed, maybe some pedal swelling, lower extremity swelling, maybe.
It's going to be difficult to tell that because remember, one of the problems that pregnant females have, especially in the late term, is that they're going to have pedal edema anyway. So look for signs and symptoms of shock, increased heart rate, reduced blood pressure, altered mental status, pale, definitely, maybe diaphoretic going along and through this way. So again, because it's reducing it coming back, now those signs and symptoms of shock are going to be in there. Now, this is the thing that you have to watch, ladies and gentlemen. And you guys would be very, very good at this, in my opinion. Make sure that you get a good baseline assessment of your patient at the scene so that you can compare and differentiate what is happening if your patient begins to crash to go into shock on the way into the hospital. Again, the very first thing that you want to do, and actually in this situation, you don't want to put mom into a supine position to begin with. Whether she's on a backboard, if you decide that you've got potential spinal injuries or not, we want to tip her up on her left side. So roll her up on her left side, let gravity be your friend. It basically just kind of rolls the fetus off of the inferior vena cava, restores preload, and everything is fine. Now, in a cardiac arrest situation, how would you deal with this? Because exactly what Tom said a while ago about decreasing preload is going to be exactly true on a pregnant patient that's in cardiac arrest while you're doing compressions. So how do we offset that? Bella, how do we do that? Tell me how.
Just say have one person that can't do as much, just hold the stomach on both sides.
Yeah. Yeah, so basically you got one person and they are literally pulling the stomach, the abdominal area over towards the left. We can't tilt the backboard up on one side because that's going to be impossible, Joe, to do any kind of efficient compressions on mom if she's in arrest. So she's got to be flat. But we got to get that fetus off of the inferior vena cava so that we can restore that preload and do efficient compressions. Again, if you're going to tip mom up like this and she's on a backboard, please, please, please make sure that you have securely strapped her to the stretcher. Remember, it's friction that keeps us from sliding back and forth on that stretcher. And if all that is coming into contact with the stretcher is the edge of the backboard and the backboard is not securely strapped, when your partner either accelerates, it's going to slide backwards, or if they brake, now it's going to have to brake hard. It's going to slide up towards the front of the ambulance, leading to some potential additional injuries for our patients. Generally, what we're looking at is that the gender of the fetus is determined by about 16 weeks gestation, and at about the 20-week mark, you can hear fetal heart tones if you're utilizing a Doppler stethoscope. Some ambulances carry Dopplers on them. Most of them do not. Generally, what we're looking at here, and this is an important number to remember, okay? So I'm going to stress this number. 24 weeks is typically known as the age of viability. What does that mean? It means that the baby has the best chance of survival once they hit 24 weeks, as far as if they're born premature. They're still going to have some issues. They're still going to have some problems. But as far as survivability of the fetus, if it's born prior to, it's very, very rare. Prior to 24 weeks, it's very, very rare that that fetus will survive. Again, what do you think would be the biggest issue as far as underdevelopment in a premature infant? What organ system?
Lungs.
Bingo, lungs. So understand that if you're going to have to deliver a premature infant, immediately begin to think, man, I'm going to have to ventilate. I'm going to have to resuscitate. And unfortunately, we don't carry premature equipment on our truck. So you're going to have to get creative as far as how you ventilate this and going through. Fetuses that are born after 28 weeks have an excellent chance of survival, although there will still be some issues, again, primarily with their lungs. When the baby hits 38 weeks, it's considered to be full term. Now, the gestational period typically will go 40 weeks, but at 38 weeks, it's kind of like the baby is developed. It's just waiting for the whole process to come into play here. Now, most of the organs are developed during the first trimester. This is where we see some of the largest changes and some of the most physical changes that occur within the baby and the mom as this is beginning to go through. The first trimester is when the baby is most vulnerable to birth defects, whether they be genetic or whether they be caused by lack of prenatal care or use of things such as alcohol, drugs, and cigarettes. We know that the fetus is going to get all of its nourishment and its oxygenation from mom by way of the placenta through the umbilical cord. And that's going to be the lifeline for this. Now, in the fetal circulation, the blood is shunted around the lungs because mom is doing all the respiratory effort for the child, for all of the gas exchange. As far as the GI system, there's very little blood that goes into the GI system as well. Now, we'll talk a little bit later on about the development of the GI system, and in particular, how some of, particularly when a baby is in distress, it has a special substance within the intestinal tract called meconium. And when the baby is stressed, the baby will express that. It'll have a bowel movement. And this is something in the past we literally went all out for, as far as having, it's kind of like, oh man, this is a bad thing that has happened. It's not nearly as bad depending upon what you find on your assessment. And we'll talk more about that in just a little bit. The umbilical vein connects to the inferior vena cava by way of a structure that is known as the ductus venus. Ductus venus. I will not ask you about that particular name, but what I do want you to know is about the foramen ovale. The foramen ovale is a hole that's between the left and the right atria, and it allows both oxygenated blood and deoxygenated blood to mix as it leaves the left ventricle going out into the aorta. This is one of the reasons why when you deliver a newborn, they will often be as blue as the center of Tom's shirt there. That's not unusual. The big thing is going to be if that baby does not begin to pink up right away. Now, as it goes through, this blood enters into the aorta, or not into the aorta, but into the pulmonary artery, which causes the blood to now bypass the lungs, which basically are uninflated. We'll talk more about how the lungs are triggered to work when we get into the birthing process. Now, this deoxygenated blood has a lot of waste products in it, including lactic acid as well as carbon dioxide, and it comes out of the fetus by way of the liver. Again, we get some purification that is going on with this whole process of coming out. The other thing to remember, and I think we talked about this a little bit, but I want to stress this again. When you deliver a child, Kira, make sure you leave more umbilical cord than what you think you're going to need, because that is your easiest route to get an IV started on your patient. The danger of that is because we're going to want a fairly long IV catheter in there. Again, if we cannulate the umbilical vein and we have short cord, long catheter, that catheter can actually make contact with the liver, causing damage. And we can put our baby into some type of liver failure. So again, minimum of 6 inches of umbilical cord. I've delivered 14 babies over my career, and I generally would always leave about 8 inches because the umbilical cord is going to fall off anyway. So let's make good use of it as far as when we're taking and looking in that. Now, the baby's first breath. There's a lot of first for babies, but generally what happens now is that as the baby is descending down into the birth canal and it passes through the floor of the pelvis, the chest gets compressed. Several things happen at this exact same time. Number one, the lungs are full of fluid, okay? And that's normal. So that fluid is going to get expressed out of the lungs. The pressure inside the lungs, will that go up or down as they're being compressed? It's going to go up. Yeah, very good. So it's going to go up. That sends a signal. That sends a neurological signal to the baroreceptors that are located in the brain that, kid, you're on your own now. Mom has done all the breathing for you that she's going to, and now you need to begin to breathe. So as it is compressed and now it opens up, basically it's the same way that we're breathing right now, is that we lower the pressure, air flows in. We increase the pressure, air flows out. The baby's lungs are compressed, the chest wall is compressed. And remember, babies are their rib cage is very, very pliable, very, very flexible. Not like ours that's been calcified, but it compresses, expresses all the amniotic fluid that's in the lungs, and now as it comes back out, it opens up and it pulls air in. This is why when we get into talking about like a prolapsed cord or shoulder dystocia, it's critical that we make sure, Joe, that if the baby gets stuck in the birth canal, we've got to open that area up because the baby is going to start breathing. And so if the birth canal is kind of like this on the baby's face, the baby will indeed suffocate, because it is still getting some oxygen and carbon dioxide removal through mom as long as that umbilical cord is pulsating. But now most of that begins to shut off. Now, the ductus venosus that we talked about a while ago begins to close and it stops the blood flow from the placenta. How are we going to be able to know when that occurs? Kind of already given you the answer. How do we know when mom has stopped physically supporting the child? Now she's going to emotionally and financially support the child. For, as a parent, we support our kids for the rest of their lives, but I mean in different ways. But how do we know that blood is now no longer flowing from mom into the baby?
The baby's going to breathe.
It's going to breathe. But now remember, we still have some blood exchanges taking place early on between mom and baby.
The cord's no longer pulsating.
Bingo. And this pulsation of the cord can be felt more than seen. Remember, I don't remember. I was thinking somebody in here had delivered or helped with the delivery or saw something at a delivery, and they were talking about the cord. The cord is really, really fibrous, so you're not going to really see much of it, kind of like a pulsating sensation that's going through with the mom and baby as far as that goes. But when you put your fingers on it and you compress it just a little bit, Tom, you can definitely feel when that blood is being sent through in there. As the baby continues to breathe, guess what happens? Blood pressure now begins to go up. And remember, what did I say the foramen ovale did? What is the purpose of the foramen ovale?
It allows blood to bypass the lungs to the right and left atrium.
Perfect. So that foramen ovale immediately begins to close, okay? Generally, it will completely close within about 5 to 7 days. If you ever hear anybody talk about, well, my baby was born with a hole in its heart and they have to go in and surgically replace it, I always smile when I hear that, because all of us in here were born with holes in our heart. That's the foramen ovale, but the foramen ovale did not close correctly. Generally, that's a really simple procedure. They go in and they do it shortly after birth, closes it up, and everything now begins to come into play there. Now, little discussion question here is, what might you see? And I've kind of already alluded to this, but what might you see in a newborn, baby that you've just delivered, when these structures don't close up appropriately? How might the baby present? Tom?
Hypoxia.
So definitely hypoxia as a result of what?
Not getting oxygen
Why?
because it's bypassing your lungs.
Yeah. So basically, we don't have good normal circulation. Now let me ask you a question. This hypoxia. Now remember, what did I say that the babies are going to look like when they're born? They're going to look like little cone-headed Smurfs. Okay. Burn that image into your head, because the babies that heads come out, they'll sort back. I mean, they'll become a normal shape most of the time. They'll become a normal shape, but they come out and they're really, really blue. Where we begin to get concerned is if that blueness does not begin to go away, or if we begin to see some pinking up of the extremities, but not of the core. Why are we concerned about the core of the baby's body, also known as central cyanosis?
That's where everything's coming from.
Yeah,
The cord's not working to help.
that's the core of the body. So yeah, you're exactly right. So as we look in here, we have the heart, we have the lungs that are now just beginning to function the way that they're supposed to. So watch for that pinkening up, okay? And we'll talk a little bit about how to measure that. Now, there are some pre-existing conditions that we can see in mom that become exacerbated or be made worse. Patients who are diabetics, either type 1 or type 2 diabetics, really become quite unstable during the pregnancy process. At one point in time, women that were diabetics were discouraged from becoming pregnant, just simply because it was too much of a risk both to her as well as to the baby. Now, there is a type of diabetes that develops, it's called gestational diabetes, and it is only there during the pregnancy. And the cure for gestational diabetes is delivery of the fetus. The diabetic problems that mom would experience during the pregnancy disappear almost immediately once the fetus has been developed. Now, here's the thing to keep in mind when you're getting your assessment and getting your history on your patients, John, is that if mom says, number one, I'm a type 1 or type 2 diabetic, or I have gestational diabetes, you got to be really concerned because babies born to diabetics typically become very large. Many of these babies are delivered by C-section. So now, if that occurs within your situation, and remember, we talked at the beginning of this, that if you've got a patient that has had good prenatal care, that doesn't have any pre-existing or hasn't developed any existing problems within the pregnancy itself, that a delivery is not an emergency. You don't have to run lights and sirens to the hospital once you've made the delivery if everything is going well. As a matter of fact, I would encourage you not to. It will be much safer for everybody that's in that truck. But again, if you've got a mom that is in active labor and she tells you she's gestational diabetic, that is an emergency. Why? Why should you consider that an emergency? Bella.
The baby's super large, and might have trouble coming out.
Yeah. Mom is not going to be able to deliver an 8.5, 9, or even a 10-pound baby. There are records that show that some of these babies have weighed as much as 10 pounds. That's huge. The trauma that's going to happen to mom is definitely going to be threatening to her, but it's also going to be threatening to the baby. So we got to get that mom into a place of where a C-section can occur. So again, making sure that you know wherever you're working, especially in rural areas, as to whether your hospital has OB services or not is going to be critical. And this may be one of the few times when you might want to fly mom. I mean, so for example, I started my EMS career down in Jellicoe, and they had OB services back then. This was back in the 70s. But the hospital down there no longer does OB. And so they have to either send their patients down to Knoxville or they go up to Corbin. And again, going from Jellicoe up to Corbin, you're looking at probably about a 40-minute transport. If this is this mom's third, fourth, or fifth baby, that's not good. So you may want to consider flying mom to the nearest appropriate facility. If indeed, Tom, flying is the quickest way to get them there, okay? So diabetics you want to watch. Heart disease becomes really, really worse during the pregnancy. Heart failure or congestive heart failure could potentially develop in a mom that has heart disease or has a history of hypertension because of the increased cardiac output. And remember, Joe, we talked early on that the blood volume inside mom increases by how much during pregnancy?
I forgot.
That's okay. Anybody remember? 50%. 50%. That's a lot of fluid. So again, if mom has any kinds of problems with her heart, especially with a decreased ejection fraction, which, by the way, what is an ejection fraction? We talked about this in 310.
And how much blood's pumped out with each.
You're close. You're really, really close. Can anybody add to that? Bella said, how much blood is pumped out?
Per heartbeat.
Better. Kira, you got an idea? Okay, it's all right. Ejection fraction is a percentage. It is a percentage of the blood that is ejected from the left ventricle with each contraction. Okay? Here's the thing I want you to remember. Normal ejection fraction for a patient, and sometimes you'll hear people refer to it as ejection fracture. It's not entirely right, but it's kind of like it's said enough that it's kind of become acceptable. But ejection fraction, or EF, is 50% or higher. Okay, 50% or higher. So if we get an EF that is less than 50%, now we begin to get some major problems. In the pregnant patient, we would really like to see that be at about 60% or higher, because again, blood's needed for mom, blood is needed for the baby. So heart failure could be some situation. So let's do a little bit of a review here now. What would be some of the signs and symptoms that you would see in mom if she is experiencing acute heart failure related to her pregnancy? What's one really big sign that's not good at all if you find it? Crackles in the lungs, okay? Also known as pulmonary edema. I like that. Also known as crackles in the lungs, pulmonary edema. So yes, pulmonary edema. What else would we see? A little bit of review of cardiology here.
There'd be edema, but there would already be edema if she's pregnant. So it's like
yeah, so the edema would be there, but it may be worse. But then again, Tom, you're exactly right. It's kind of like, is that the edema from the pregnancy, or is that the edema from her heart failure? Very good. Remember, some of the other things that we will see here is if we put her at a 45-degree angle, what happens to her jugular veins? Poof! They pop way out there, okay? Shortness of breath. Many times this patient will have really, really bad shortness of breath, which is even worse for the OB patient because, remember, they can't tripod. So in that situation, if it is really, really bad, how might they try to tripod? What might they do that would lead them to help as far as that whole process of tripoding, even though they've got this large belly? They won't lay down because of the pulmonary edema. But many times you'll see patients that will literally begin standing up, and this is a type of tripoding as well. And what they're doing is they're trying to get the belly out away from the diaphragm so that the diaphragm will have more room to work. So in that situation, you may literally have to have your patient, Kira, sitting up on the side of your bed with their legs dangling. And actually, that's going to be a good thing. Why? Why would their legs dangling be a really, really good thing for heart failure patients, in your OB patients, as well as all the rest of them? John, what do you think?
Blood up here.
Tell me more. You're on the right track. What does dangling of the legs do? Tom. Oh, a touchdown. Remember, when we dangle our legs, it reduces preload. And that's what we actually want to do for our mom here, is to reduce preload. We want to reduce the amount of volume that's coming back, okay? Hypertension is made worse by pregnancy. Everything is made worse by pregnancy because, again, we've got this alien life form that's developing within inside mom, and it can now also lead into a problem with a placenta known as what? You should have covered this in your EMT class. Patients with hypertension, especially if it's uncontrolled or if it's exacerbated by the use of methamphetamines, OB patients can develop what condition? And it's life-threatening. Preeclampsia can definitely come in there. Hypertension is definitely one of the symptoms of preeclampsia, but abruptio placenta, where the placenta begins to tear away. And we'll talk more about that in just a little bit. Again, if mom has a history of seizures that's controlled by meds, it is possible for them to have a good, healthy pregnancy as they're moving on through and not have any problems with that. But again, remember, many of the seizure meds that mom takes will cross the placental blood barrier, which will cause many physicians to have to change up the meds that mom's taking to manage her seizures. Anytime that there is a change in meds for a seizure patient, it always increases the risk of our patient having a seizure. And what's the big concern that we have with patients that are seizing? They're not breathing, okay? If mom's not breathing, baby's not breathing either. So that's the thing we also want to keep in mind. So how do we approach our OB patient? What are some of the things that we're going to do to begin to kind of look at and assess? Well, first of all, our assessment of the OB patient is going to be the exact same as we would for a male patient. We're going to start off with our scene survey, looking at things that are happening, whether it's a trauma or if it's a medically related issue. We're going to look at the surroundings and find out and draw clues from that. Again, airway, breathing, and circulation are going to be critically important, and even more so important in this situation. We have to keep in mind that our assessment findings are going to be skewed a bit because of the developing fetus, which means what for our patient when we're going to get vital signs? What will we expect to find on mom as far as her heart rate? It's going to be higher. Respiratory rate. Blood pressure. Lower. Blood pressure is usually going to be lower. Joe.
Depending on position, could the blood pressure vary? Like if she's laying down compared to standing and sitting up?
And that is true. There's a I won't say a controversy, but there's a difference of opinion on whether postural hypotension actually exists. Based on what I've read, I believe that it does exist, but I don't think it is as serious as what we thought. But most definitely, if mom's lying down, you got to keep in mind, gravity is not affecting her nearly as much as if we sit her up or if we stand her up. So yeah, you're exactly right. The positioning of our patient can most definitely come into play there. So that would be important as well. So these are all important things to remember, because remember, when we have a low blood pressure and an increased heart rate, Kara, what do we automatically begin to worry about?
Low blood pressure and your start rate.
Mm-hmm.
Like signs of shock.
Bingo. So we're concerned about signs of shock. It could be that mom is indeed having symptoms of shock, either from a medical concern or more likely from a traumatic concern, or it could be simply that mom is having a normal pregnancy. And again, this is why the vital signs have to be watched so closely, because they can mask, they can cover things that are beginning to occur within the mom. Get your sample history on your patient. Now, the other thing I want to share with you, especially in the summer when we start doing some of the scenarios, please, 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 and I've told you this before, I'm going to tell you again, don't just vomit out what sample means. I want you to have a conversation, regardless of what the patient scenario is, Joe, I want to hear you talking with a patient and getting that. Trust me, if I'm sitting there and evaluating it, I'll know what you're asking about. And then even if I don't, if I come back in a debrief and I say, well, you didn't ask about the patient's prior medical history. And you can say, well, yeah, I did. I asked them, do you have any medical issues? I go, okay, well, I missed that. All right, that's fine. That's awesome. So again, I want you, when you're doing your sample and your OPQRST, is it drives me crazy for people just to say that, because that's not what you're going to do with your patient when you're actually working with them. Couple of key important things here that you've got to determine. Number one, find out if mom has had prenatal care. The good news is now most women will have prenatal care, but you're always going to have the one outlier for whatever reason. Okay? For whatever reason. And it may be valid, but so withhold any judgment, because right now we're concerned about our patients as people who tell you, I've had no prenatal care. That changes the situation dramatically because now we don't know, especially if mom is in labor, now we don't know are we going to have a normal delivery or we're going to have an abnormal delivery. Are we going to have one baby Tom or are we going to have multiple babies? You know, is there an issue that's going on here? The other thing to keep in mind is to ask, have you had a cesarean? Have you had a C-section in the past? Not all women who have had C-sections in the past have to have C-sections for subsequent deliveries, but most of them do. Why do you think this would be? First of all, let's make sure everybody understands what a C-section is. What is a C-section?
They just cut open your stomach pretty much. You grab it.
So yeah, they'll open up the abdominal cavity and they also open up the uterus and they go in, and rather than being a vaginal delivery, now the baby is not. Let's see how well you were listening a while ago. What kind of concerns, and C-sections have become fairly routine, but what kind of concerns would the OB doc have with a baby born by C-section as opposed to not having those concerns with a vaginal delivery?
The lungs.
Man, I love being around smart people. Yeah, you're exactly right. The lungs have not been compressed, okay? So the doc is going to have to stimulate the baby to begin to breathe. And again, they're going to have to use some fairly aggressive suctioning to get that amniotic fluid out of the lungs. Excellent job. So again, find out if mom has had a C-section. Again, if she has and delivery is imminent, in my opinion, that would warrant an emergency transport. Why? Because remember, when mom heals up, she's going to have a scar. And then the thing to remember is she's also going to have a scar on the uterus. That is a weakened area. When the uterus contracts and when it is stretched during a vaginal delivery, that can tear. What really bad thing happens when we have a torn uterus?
Bleed a lot.
Bleeding profusely. Kira,
So I actually got to see a C-section.
did you? Tell us about it.
So I saw two, and one was emergent and the other was scheduled. And for the scheduled one, she had a history of a C-section, the prior one. And when they went to perform the second C-section, her uterus had actually fused to her abdominal walls.
Mhm.
So when they were like cutting her open, they tore off part of her like abdominal wall. So she started to hemorrhage.
Yeah. Yeah, and that's not unusual with any kind of abdominal surgery. You'll never be tested on that, but fun fact to show your knowledge, that fusion is known as an adhesion. Adhesion, where when it heals up, it literally will fuse to the abdominal wall. My wife has an adhesion, not because she had a C-section with the delivery of our child, well, our youngest daughter, but remember, she gave me a kidney a long time ago, and at that point in time, literally, they would open from back here to up in here. And so when she healed up, she has an adhesion there, which causes her some discomfort every once in a while, which she is really quick to remind me of why she's having that discomfort. So, but I try to be very appreciative of what she did. So that's an excellent description there. So again, we'll talk about ruptured uterus in just a little bit. Again, ruptured uterus can come about as a result of hypertension, as well as any type of methamphetamine use that's going on. Find out if an ultrasound has been completed and if the baby, if mom is aware of any structural abnormalities to the child. This is important information that will help you to determine, do we deliver at the house or do we try to make our way into the hospital? When a patient has a condition known as preeclampsia, which can lead into eclampsia, diabetes and hypertension will worsen those, or the eclampsia will increase the possibility of both hypertension and diabetes for a patient. And again, remember, a patient that has gestational diabetes is always going to be at a much, much higher risk of a larger baby. When a mom has gestational diabetes, well, let me back up here. Let's do a little bit of review. What is the big issue with patients that are diabetics, whether they're type 1, type 2, or they're gestational diabetics? What is the big danger that we're really concerned about with diabetes? What's the long-term effect?
I was thinking like how effectively the sugar nutrients are going to get into the baby.
So we're always going to be concerned about that, because you're exactly right. Remember, the brain cannot store oxygen, the brain cannot store glucose. And so both mom's brain and in particular the baby's brain is going to be a big concern. But now remember, in diabetes, most of the time the concern is not about a low blood sugar, it's about a high blood sugar. So what are the repercussions of a chronically elevated blood glucose level? John?
No, it deteriorates vasculature.
Bingo. Remember, it deteriorates vasculature. The vasculature, if mom, especially if she develops type 2 diabetes, she's only going to have it for about 40 weeks or so. So the chances of that having a long-term negative impact on her, not really big. It can, especially if she has a history of type 2 diabetes or type 1 diabetes that's not well controlled. That changes up everything. But remember, the baby is developing inside mom, and the baby goes from basically one cell from mom, one cell from dad, and now they begin to multiply. And as those organ systems now begin to develop, that increased glucose, think of it as acid. If it can begin to dissolve inside of the arterial system, leading to poor perfusion. When we have poor perfusion during the fetal development, we have poor organ development, which results in all kinds of, especially as you were talking about a minute ago, the development of the lungs that would come into play there. Babies that are born to diabetic moms also have problems maintaining their temperature. Remember back how OCD I was in trauma about telling you about keeping your patients warm? Well, it's the same way when you deliver a baby. You should never deliver a baby that is hypothermic because of you. Okay? Now, babies can become hypothermic despite everything that you do. But you got to keep these babies nice and toasty warm, regardless of what the temp is outside. And remember, if mom says I'm a diabetic, these babies are not going to be able to regulate their temperature really, really well. The other thing, as far as we talked about just a minute ago, is that these organ abnormalities that come about also come about because of the degradation of the vascular system for our patient. When we're looking at our female patient, our OB patient, remember, blood volume will increase by as much as 50%, but your cardiac output will also increase by as much as 30%. So if your patient has pre-existing high blood pressure, now we've taken a bad situation and we've made it worse. The other thing to keep in mind is that there is indeed don't leave, I promise I'll get better. It's okay. There is indeed a genetic risk of passing on to the baby a history of hypertension, leading into the baby having some issues with, again, development of the organs, in particular the heart. If mom has a history of preeclampsia, she is going to have high blood pressure. And we'll talk more about preeclampsia as a standalone illness in just probably on Wednesday. And so we want to watch that really, really closely. When we're looking at mom and we're assessing, there should be almost no bleeding during a normal pregnancy. As a pregnancy or during a normal delivery, and definitely during the pregnancy itself, there should be very little bleeding there that's going on. But if we do see some bleeding, or even if mom is reporting spotting, this could be a big, big concern. So some of the things that we want to assess our patient for, and again, these are difficult questions to ask, especially if you're a male and you're asking your female patient. And again, remember, you guys are going to be working in different places. And even if we work in rural Kentucky, we have different cultures that we come into contact with, either they're moving into the area or they're traveling through. And so you have to adjust your assessment and your history gathering based upon the situation. I think I shared with you when I worked out in Kansas, we had a large Somali population because of the beef packing plants there. And literally, we could not go in and assess a female patient that was of Somali culture unless we had could send in a female paramedic to do that. But some of the things we want to find out is how many pads are you using? Don't ask how much blood have you lost. It was really interesting. I just went to a conference, I spoke at a conference Friday out in North Dakota. And they were talking there, and one of the presenters said that in EMS, we are terrible at gauging blood loss. And I thought, yeah, I probably am. Because in high blood loss, we have a tendency to underestimate, and in low blood loss, we have a tendency to overestimate. So the thing that we do is that with mom, we ask her, how many pads have you used? Thomas, did you have a question? Okay. So we're looking at this, and then the other thing is during your transport, if mom passes any types of clots, or especially if it is tissue that she is passing, get a plastic bag, put those into a biohazard bag, and transport those to the hospital. Especially, Joe, if it's tissue, because the OB doc is going to want to evaluate that to see exactly, is this uterine tissue or is this placental tissue that's being expelled from the mom. When we do our physical exam of the OB patient, first of all, and you guys have been really, really good about this, maintain the dignity of your patient. Remember, this is a person. Put yourself in their situation. If you're in a public area and you're having to do some type of an exam, let's say maybe visually even having to check a patient for bleeding, understand that number one, mom is going to be incredibly worried about her baby. Number two, you're going to have the crowd of ooh-ah lookers, that are wanting to kind of see what's going on here, and try to, glimpse just basically at somebody else's misfortune. So maintain mom's modesty, keep her nice and warm, but maintain mom's modesty and her dignity, and try to get her into the back of your truck as soon as you possibly can. Now, if mom tells you she's not entirely sure how far she is along, there is a simple and fairly easy way for you to get that. What is that process? You should remember this from your EMT class. How would we do that? Mm-hmm. If mom tells you, let's say if mom says she's obviously pregnant, And mom says, I haven't had any prenatal care. I'm not really sure how far along I am as far as in the gestational process. What is an easy, simple, yet fairly accurate way of you to determine how many weeks she is?
Maybe how long she's had her last period.
So you can start that. That's an easy way, not always accurate. Anybody remember something else? Open up your OB kit. You'll find a tape measure in your OB kit. It should be in centimeters. Measure to the top of the fundus, which is the top of the abdominal protrusion where mom's pregnant, right up about here. Measure it down to the symphysis pubis, which is the very bottom part down there. Each centimeter corresponds to 1 week. So if you measure it and it's 26 centimeters, you can safely assume within 1 week or so on either side of that she is about 26 weeks pregnant. Why is it important for us to try to get an idea of how far along she is in the pregnancy? What is the key reason that we do that? Kira?
I don't know if that's the key reason, but like supine hypotension, you might want to be aware of what side you want to put her on.
Definitely an important reason. So yeah, I hadn't even thought about that one. So that's a good one. Bella or Tom?
See if the baby will be viable.
Yeah. See if we've reached the age of viability. Remember that what is the basically the magic week number? 24. 24. Remember, 24 and 28. 24 is the baby's got a good possibility of surviving. At 28, most babies will survive, although they'll still have some problems that are going to be doing on that. When you get her vital signs, make sure you're getting her vital signs over on the left side or sitting upright. Never get the vital signs of mom while she is lying flat. They're going to be falsely inaccurate. Your heart rate will be up, blood pressure will be down, your respiratory rate will also increase because remember, mom is trying to be in compensated shock, which increases the respiratory rate that's going on. You can do a visual inspection of the vaginal opening. Only under certain circumstances that we'll talk about when we come back on Wednesday can you insert your fingers into the vaginal canal during a birthing emergency. Basically, what we're looking for is we're looking for crowning. Crowning is the top of the baby's head that is now at the vaginal opening. We're looking for the possibility of a prolapsed cord. A prolapsed cord means that the cord is coming out first. The danger with a prolapsed cord is the cord comes out, the head impacts it against the pelvis, and it cuts off blood supply to the baby. We'll talk about that more in detail. You want to see if the perineum has been torn. The perineum is that small piece of tissue between the bottom of the vaginal canal and the anus, and it gets stretched really, really paper thin. It's not life-threatening, but it can become life-threatening because if it tears, it's difficult for it to heal, and that's in a dirty area, so that mom now can potentially become septic going on. And again, we're looking for any types of situations in which we would anticipate that delivery is getting ready to take place. So